Hello everyone, welcome back to the channel. Today we are going to talk about the BPaLM regimen, the current first-line treatment for MDR, pre-XDR and XDR TB. I will walk you through the eligibility criteria, the exclusion criteria and the contraindications for the regimen. We will also be covering topics like what to do if a patient misses the dose or if the regimen fails, and how to follow up a patient. And finally, we will also be discussing how to manage important side effects like peripheral neuropathy and raised QTC interval. So let's get started. So what is BPaLM? BPaLM is a 6-month all oral regimen that can be extended up to 9 months if required. It is given to patients above 14 years of age with microbiologically confirmed MDR, pre-XDR or XDR-TB, regardless of their fluoroquinolone resistance or HIV status. The decision to start the treatment is made at the nodal and district TB center. Coming to the eligibility criteria, it is indicated for any new microbiologically confirmed MDR or rifampicin resistant TB. Also for probable MDR TB who failed H mono or polydrug resistant regimens, and in special cases where there is a history of exposure to the core drugs which are bedaquiline, linezolid and pretominid for a duration of less than 1 month. BPaLM regimen is also indicated in patients where the duration is more than 1 month, but there is a documented sensitivity to the drugs. There is an additional criteria here where it is important that the patient has not failed any prior treatments on bedaquiline or linezolid containing shorter or longer regimens. It is important to check QTC interval on ECG before starting our patient on BPaLM regimen. The normal value of QTC is less than equal to 450 milliseconds in males and less than equal to 470 milliseconds in females. If the values are higher, do check electrolytes. If the serum electrolytes are found to be abnormal, recheck the ECG after correcting the electrolytes. If the QTC interval comes back in normal range, patient can now be started on BPaLM regimen. It is important to note that BPaLM regimen is not indicated for breastfeeding or pregnant mothers. If a patient is pregnant and willing for MTP, she can become an eligible candidate for BPaLM regimen. Now coming to exclusion criteria and contraindications. Think of these as being opposite to the inclusion criteria. Age less than 14 years, documented resistance to bedaquiline, linezolid, and pretominid. Both of these are contraindications to BPaLM regimen. Apart from this, severe liver disease, as in the liver enzymes more than 3 times of upper limit of normal or total bilirubin more than 2 times of upper limit of normal, irrespective of signs and symptoms of liver disease, is a contraindication for BPaLM regimen. This is because bedaquiline is hepatotoxic. Severe forms of extrapulmonary TB like CNS TB, spinal TB, disseminated TB, like miliary TB, these are also contraindications for BPaLM regimen, mainly because of lack of evidence. If a patient has a history of structural heart disease or a history of long QT syndrome in past, or has a family history of the same, or has risk factors for torsidase de pointes, example hypokalemia, hypomagnesemia, hypocalcemia, or currently have uncontrolled arrhythmia, BPaLM is not indicated for these patients. It's also contraindicated in patients with baseline QTC more than 450 milliseconds in male and more than 470 milliseconds in females, despite electrolytes being normal. Now coming to relative contraindications of this regimen. This regimen is not indicated in patients who are on inhibitors or inducers of cytochrome P450 enzyme due to drug interactions. But here a clause has been mentioned in the guidelines where it states that if a patient has received these medicines for less than 3 days, or if the substances have been washed out of the body, say for at least 5 half-lives of that substance, then we can still prescribe the patient with bedaquiline based BPaLM regimen. Now, understandably, this regimen is also relatively contraindicated with other drugs which can cause QT interval prolongation, such as antifungals, antiarrhythmics, and antipsychotics. Next, it has been stated that this regimen is also relatively contraindicated if the patient was taking monoamine oxidase inhibitors within 2 weeks of starting the treatment, and it is also relatively contraindicated with SSRIs and tricyclic antidepressants. This is mainly because bedaquiline and linezolid have a weak monoamine oxidase inhibitor activity and therefore has a potential for drug-drug interaction and serotonin syndrome. It is also advisable to keep a gap of 2 hours before and after any magnesium or calcium supplements, as they can interfere with fluoroquinolone absorption. Next, it is advisable to not use linezolid containing regimens along with other myelosuppression causing medicines. So here hemoglobin less than 8 is a relative contraindication for the regimen. Next, the regimen is also relatively contraindicated in severe renal failure, as the evidence is lacking of its performance in these patients. Severe neuropathy, which is grade 3 or grade 4, is also a relative contraindication. Coming to the regimen itself, bedaquiline is prescribed at a dose of 400 mg once daily for 2 weeks, followed by 200 mg thrice weekly from week 3 to 26 or 39 weeks. Pretominid is given at a dose of 200 mg once daily, linezolid at a dose of 600 mg once daily, moxifloxacin at a dose of 400 mg once daily. Pyridoxine supplementation is advised with the regimen with 50 mg once daily if the weight is less than 30 kg and 100 mg once daily if the weight is 30 kg or more. So advantages of the regimen include lack of weight bands, lesser medicines, shorter regimen, better response owing to lesser resistance to these drugs in the community, and no complicated regimen or replacement tables. In order to prevent the development of resistance against the drugs used in this regimen, especially with bedaquiline, which I will explain next in the video why there is a risk for that, it is advised to administer 85% of the doses, that is at least 6 days per week, under direct physical supervision by treatment supporter. Bedaquiline has a long half-life of 24 to 30 hours and terminal half-life of 5.5 months. This is due to its extensive tissue distribution. Any interruption in the treatment will potentially result in bedaquiline monotherapy within first few days of interruption, and as a result there will be a high risk of development and amplification of bedaquiline resistance among the existing TB bacilli in the patient. Now let's talk about linezolid and evidence behind its dose adjustments in case of side effects. There is an Indian trial, namely modified BPaL trial. Study participants were divided into 3 groups, where one group received 600 milligrams of linezolid daily for 26 weeks, another group received it for 9 weeks, followed by 300 mg for rest of the 17 weeks. Last group received each dose for 13 weeks. At the end of the study, there was similar cure rate in all 3 groups. So this study demonstrated that linezolid toxicity could be reduced with structured dose reduction to half the initial dose after 9 or 13 weeks of treatment without affecting the outcome. According to NTEP guidelines, all efforts should be made to continue the regimen with linezolid 600 mg throughout the course, but in case of intolerable side effects, the dose can be reduced to 300 mg daily after 9 weeks of completed treatment with 600 mg daily dosage. If this can't be achieved, the outcome is labeled as treatment failed and the patient is shifted to long oral regimen after approval from nodal or district TB committee. However, it is important to remember that in case of dose reduction of linezolid, as explained, the duration of regimen will increase from 26 weeks to 39 weeks. Please remember, dose modification of bedaquiline, pretominid and moxifloxacin is not recommended during treatment. Coming to moxifloxacin, according to practical study, BPaLM was more effective in culture conversion at 8 weeks of treatment when compared with BPaL alone or with BPaL-C with glufazamine. This highlights why moxifloxacin is crucial to the regimen irrespective of its sensitivity or resistance status. Other reasons highlighting the importance of moxifloxacin includes lower TB recurrence seen with BPaLM. There is a probable protection against amplification of bedaquiline resistance when used with moxifloxacin, as there was zero resistance noted in BPaLM group as opposed to the other groups in TB practical study. The safety outcomes also favored BPaLM, as lower percentage of patients had grade 3 or higher adverse events in this group. Finally, the QTC interval at 24 weeks was lower in BPaLM group than standard care group, where the QTC was comparable to that in BPaL clofazimine group, highlighting clofazimine's role in raised QTC interval in these bedaquiline containing regimens. US programmatic data also stated 0% relapse rate in BPaLM as compared to 3% with BPaL. However, at this point, I also want to highlight that in case of grade 3 or 4 intolerance to moxifloxacin, it can be dropped from the regimen and the regimen be completed as BPaL. But this regimen needs to be extended to a total of 39 weeks from 26 weeks. So this is the second reason for regimen extension besides linezolid dose reduction as discussed before. Now coming to what to do if a patient misses the dose. It is mentioned in guidelines that a total of 26 or 39 weeks of treatment should be completed with all three core medicines, which is bedaquiline, pretominid and linezolid. So this implies that at the number of missed doses to the treatment, if consecutive interruption was less than 2 weeks or non-consecutive treatment interruption was less than 4 weeks, and reintroduction of regimen post cessation can be done if less than 4 weeks or 1 month has passed. In case of reintroduction, approval of nodal or district TB center should be sought. In all other cases, treatment is declared as failed. In case of treatment failure due to any cause, patient becomes a candidate for long oral regimen of MDR TB regimen. This table can be referred to for follow-up assessment. Improvement in weight and sign and symptoms is a proxy marker of the drug effectiveness. CBC ECG needs to be checked at day 15 and day 30 and then monthly. Visual acuity and color vision tests to be done at week 9, 13 and 26. Culture to be sent monthly starting from end of second month, chest x-ray at the end of third month and then at the end of treatment. Long-term follow-up needs to be 6 monthly till 24 months or 2 years of completed treatment. This is to look for relapse. Culture conversion means positive culture becoming negative after treatment, and reversion is culture that was previously negative but now turned positive. This can happen at any point of time if resistance develops and thus needs a close eye. Now coming to side effects of linezolid, optic neuritis warrants permanent discontinuation. Grade 2 peripheral neuropathy warrants halving the dose to 300 mg with possible drug holiday for 1 to 2 weeks, while grade 3 or 4 neuropathy warrants permanent discontinuation of the drug, except sometimes when neuropathy improves after 1 to 2 weeks of drug holiday. It can be restarted but with very close observation for worsening of neuropathy. Myelosuppression is usually reversible with drug holidays. Severe anemia may need blood transfusions or erythropoietin hormone. More than 10% fall in HB or fall in platelets or WBC count from baseline indicates clinically significant myelosuppression. Now, how to identify and grade the peripheral neuropathy? Sign and symptoms include numbness, burning, pins and needle sensation in the feet, feeling hurt when bed covers touch the skin, inability to distinguish hot or cold water while bathing, slipping of the footwear without one's knowledge, inability to place the soles on the ground, frequent sores or ulcers on the feet, worsening of symptoms at night, or increase in leg pain while walking. There is a screening tool in an annexure of NTEP guidelines. This can be referred to ultimately grade the degree of peripheral neuropathy. It provides measures for amount of interference experienced by the patient in their walking and sleeping habits due to neuropathy, and its severity is graded on a scale of 1 to 10, 8 or more being severe, 4 to 7 being moderate and 3 or less as minimal. Questions like pins and needles, burning, pain in feet or legs and numbness is graded by showing a visual analog scale of severity of these symptoms. Vibration perception is also checked and graded, and so is the ankle reflex. After that, this table helps in grading the severity of peripheral neuropathy mainly based on the degree of interference in day-to-day activities. Medical treatment includes NSAIDs, PCM, pregabalin and methylcobalamin supplements. Gabapentin or gabapentin NT can also be tried. Treatment with tricyclic antidepressants needs to be closely monitored for risk of development of serotonin syndrome due to interaction with bedaquiline, which is a mild monoamine oxidase inhibitor. Avoid duloxetine with linezolid as it may cause serotonin syndrome. Now this table shows the management of long QTC. If QTC is more than 500 milliseconds, stop all drugs at risk of causing long QTC. Say bedaquiline, moxifloxacin, pretominid and clofazimine. Check serum electrolytes if abnormal, correct them. Repeat ECG daily. If not possible, then at least twice a week. Check QTC interval. If it comes below 470 milliseconds, reintroduction of drugs is done in the order of bedaquiline, moxifloxacin, clofazimine and pretominid. Only if Two consecutive ECGs done 24 hours apart are showing QTC interval to be less than 470 millisecond. Only then a reintroduction should be started. This should be practiced after every drug's reintroduction. This slide shows the order of reintroduction as discussed before. Patients with QTC interval more than 500 milliseconds should be hospitalized and closely observed for life-threatening arrhythmias, and also for close monitoring following the reintroduction of the drugs in these patients.